Hello, everyone. Thank you for joining us today. It's not quite at the top of the hour yet, so we're going to allow a little time for everyone to come in from the lobby, and then we will get started. All right, it is 11 a.m. Central Time, so I'll go ahead and get us kicked off today. Hello, everyone, and welcome to the Rural Health Executive Educational Series. I'm Cody Smith, the Director of Rural Partnerships and Leadership Development at NRHA Service Corporation, and I'm thrilled to be your moderator today. Before we dive in, there are a couple things to know. This session is being recorded, and we'll email the recording to everyone who registered later today so that you'll have access to all the key points and insights shared. At the end of the session, we do ask for your feedback. It's through a really quick, short survey. Your input does help us make these sessions as relevant and useful as possible for you and your peers. Quickly cover a few housekeeping items. All attendees are muted, this just to keep things running smoothly. The presentation, we usually say this runs about 45 minutes to follow some or leave some time for Q&A. This one is really important, impact with lots of good information. So it may go a little longer. Don't hesitate to drop any questions that you have at any time into the GoToWebinar control panel. It's your chance to really get some great information from our experts. Today, we're fortunate to have two exceptional speakers with us, Opal Greenway, Principal with Stroudwater Associates, and Megan Zook, a consultant with Stroudwater Associates. Today, they'll share the 2024 Rural Provider Compensation Survey results. Before we begin, a big thank you to Stroudwater Associates, a platinum partner and a cornerstone of our partnership program. Their unwavering commitment to advocacy, their depth of expertise, and their dedication to advancing rural healthcare really makes them an invaluable part of our efforts to support rural communities. We're truly grateful for your ongoing contributions and collaboration. With that, let's get started. Opal, I'll hand it over to you.
Thanks, Cody. All right, well, we are excited to be presenting for the second year in a row our Rural Provider Compensation Survey. I would like to go ahead and thank NRHA and also the National Organization of State Offices of Rural Health, who helped sponsor this survey and help us distribute it each year out to the different hospital and provider organizations out there in rural to find out exactly what are we paying both physicians and advanced practice providers. So today we're going to go over the survey results. We're going to talk about what how we put the survey together, some changes that we made from last year, and those changes come directly as feedback from those that fill out the survey and those that listened to the presentations and downloaded the survey last year. We'll go over a review of the findings for both primary care and specialty care, as well as go over some other components of compensation that we gathered data on. So digging right into the compensation survey, we were thrilled to have 199 respondents this year, so up from last year's when we had 156 survey respondents. We did have survey respondents that ranging from independent hospitals that had fewer than 10 staff beds to system affiliated hospitals with more than 150 beds. As you can see, we did have a huge increase in the number of health system respondents this year, going from 43 respondents to 79, recognizing that there's been a lot of consolidation going on in the industry. A lot of rural hospitals have now become part of small rural regional systems and larger systems that are being consolidating. We did, but luckily we did still, the information is really interesting to see how that we are still skewing significantly towards those independent hospitals, as rural hospitals are the ones that we're seeing most in need of getting data in front of them. Most of them do not have access to some of the large expensive surveys out there that oftentimes do not have rural specific information. We do look at our survey responses by different regions. So this State Offices of Rural Health works with the Federal Office of Rural Health Policy and has these different regions. And so when we look at our response rates by regions, we had responses from 42 out of 50 states. 5 of the states that did not respond, you can see our New England states that do not have any critical access hospitals, such as Connecticut, Rhode Island, and New Jersey. We also did not have response from South Carolina or Idaho. So if we have any representatives from Idaho or South Carolina on the line today, hopefully we can encourage you to have responses from your states so we can get good information specifically from your different regions.
Hey, Opal, I'm going to jump in for just a second. We are having a little trouble with your screen. Cody, maybe you wouldn't mind sharing, and that way everyone can see some of the slides that Opal is sharing.
1 second. Megan, do you have yours up? I'm going to send it over to you as the presenter, and then I'll get mine.
I also have mine open too, if that's helpful.
Let's see if that works. Sorry about that. It's a little slow today. Okay. Megan, did that open up for you?
Yep. Are you all seeing my screen?
Yes, absolutely.
All right, I'm on slide 7, Megan. Sorry about that.
Oh, technology. It's always fun, right?
All right.
Oh,
And this was with us getting on early and checking everything out previously. So, well, thank you everyone for your patience on this. But as I was talking about, going back into discussing the different regions, when we look at it, we have our overall region responses. Region C had the most respondents, same as last year, although because we had more responses this year from some of the other regions, Region C made up 28.4% of the overall responses. Region A, which is the region, that New England region that actually has several states in it that do not have necessarily critical access or rural hospitals due to population density, at 16.7. Interestingly, Region B, which is actually, I'm based in Tennessee, which is where Region B is. We actually have a very low response rate of them only making up 6.6% of the total respondents. When we look at this information, interestingly, Region A is the only region where we had more respondents that are responding from a system level. A lot of that has to do with a lot of the consolidation that we see in states like Pennsylvania, West Virginia, New York, where we see a lot of rural hospitals being part of a system, even if it's just a 2 or 3 hospital, smaller regional system, but a lot of hospitals being involved with some sort of larger affiliation like WVU Medicine in West Virginia. Not surprisingly, Region E had the highest concentration of independent responses at 77.6 of the respondents from Region E were independent. Keep in mind, Region E is inclusive of that, the Northwest, as well as North and South Dakota, Colorado, Wyoming, and Utah. So not surprising that we see a lot of those being independent hospitals and are not necessarily affiliated with larger systems. So moving on to the next slide, just some things about the study process. What we asked for was specifically were for people to respond with total compensation paid. We use we are consistent with what MGMA, Sullivan Cotter, and some of the other large surveys out there use for requesting compensation information. So we're talking about box 5 of the W-2. When we issue the survey, we specifically ask for that information. It's usually easy for people to pull. We run the survey in the first quarter of the year. And so that way people have the W-2s from the previous year to be able to provide that information. The reason why I emphasize this so much is I think a lot of people who engage with survey data sometimes think that the survey data may just represent base compensation. And so providers will ask for, okay, here's median base compensation, thinking that it is base compensation, and then ask for add-ons on top of that, which will increase the total compensation. So we always make sure we're emphasizing that the data represented in here reflects total compensation unless specifically indicated otherwise. We do ask the different organizations to indicate employment status, since oftentimes W-2 employees are paid differently and oftentimes at lower rates, since they do have benefits packages that are not part of what is considered total cash compensation, such as PTO, health insurance, dental insurance, 401ks, other different kinds of retirement benefits, whereas a contracted 1099 provider may be paid higher to account for the fact that the organization is not directly providing them those type of compensation. We also had organizations report out their size based on revenue and bed numbers, and we had them indicate whether or not they were part of a health system, if any of the hospitals in their system that they were reporting for, or if they were independent, had critical access hospital status, and whether or not the organization had any rural health clinics. During today's webinar, we will go over some of the results of comparing organizations that had RHCs versus not, CAW versus not, system versus independent, but the full results are in the survey that is downloadable immediately after this presentation. So with that, I will point out a couple of limitations that we had with regards to the survey. We actually brought the survey in-house this year compared to last year so that we could ask for additional data. So you're not going to see much comparisons from prior year survey where people responded with regards to ranges of compensation, since organizations based on their feedback said that they were willing to provide detailed information and put in specific compensation information. We decided to go ahead and bring the survey in-house so that we could do better analysis with that information. The data is self-reported by the organizations. We do not ask them to provide their W-2s to validate the information. And then anytime we got too few of responses that would to feel like it was relevant, we did indicate that with an NA. So when you're downloading the survey, that you can see that. So moving on. Just letting you know some different types of compensation that we did find out from people is there was a slight improvement of number of organizations that said that they pay just 100% base salary. So previously that was 56% of organizations. Now 54.7% of respondents say that they pay entirely straight salary with no sort of incentive compensation. 32.1% of organizations said that they do provide some sort of incentive compensation, with 31% providing a form of production bonus. The types of production bonuses could have been based off of work RVUs, patients per hour. Some organizations even said that they use charts closed per hour, which is a new one that I have not seen before with regards to incentive compensation. People also used RHC visits, patient panel size and growth, and the percentage of collections. Very few organizations provided quality incentives, which we'll get into a little bit more later. And then on some additional types of compensation that people provided were with regards to student loan repayments, with that averaging $41,000 per provider. 68 respondents said that they provide sign-on bonuses, with the average amount being $36,000 across the different types of providers. And then several organizations paying retention bonuses, averaging about $20,000 per provider per year. So let's dive into primary care, where we had the most responses. Unsurprisingly, most of our organizations that responded do employ primary care providers. The independent hospitals, unsurprisingly, do report paying more than the health system counterparts when we look at this. So you can see on here, for an employed provider, often the independent hospitals are averaging paying a family medicine with OB physician $385,000. Again, that's total compensation inclusive of any sort of incentive compensation. Whereas those that are part of a health system are averaging, median comp was $282,000. Now, if we go to the independent contract physicians, total amount of spend per provider was about $250,000 for an independent hospital and only $100,000 for health systems. One of the reasons why this might be, because this was somewhat surprising for us, since independents tend to get paid more, is that those that are providing independent or contract physicians, that they're either doing it on a, it's prorated for using only specific days per week, or they're contracted in multiple departments of the hospital where they're maybe providing hospitalist or ED services. And this is the compensation that is being reported for clinic-based family medicine with OB. One thing I'd like to point out is I thought it was really interesting to look at the differences between what is the compensation getting paid with organizations that have rural health clinics versus those that do not have rural health clinics. As you can see in the chart, those that have RHCs have a much wider range of compensation that they're paying to these physicians, but overall the compensation does seem to be higher, with median compensation for those organizations that have a rural health clinic being $382,000, which is a good $100,000 more than organizations that do not have rural health clinics. And also you can see on the max side, we do have a very high end on the range for those that have rural health clinics at $621,000 versus those without RHCs on the high end, that tight range of only 258 to 295 on the high end. So with that being said, keep in mind when it comes to a physician position within an RHC, some organizations are paying this family medicine provider in the RHC primarily to do supervision, and they're doing it because of the restrictions within their state. We've worked with several rural health clinics where the physician is primarily there only maybe one day a week, but they're paid basically as the medical director of the rural health clinic. So that might account for the low end of the range for the RHC, where the physician is not necessarily practicing within that RHC full time as a clinician. As opposed to in non-RHCs, more likely you are going to have these are representative providers who are providing direct clinic care all the way from the minimum, all the way from the maximum. So moving forward to family medicine without OB services. So these are just doing primary care. They're not going to be on some sort of OB rotation or providing any sort of coverage for deliveries that we often see in rural. Again, those that have the RHCs have a much wider range of paying $125,000 to $638,000 versus the non-RHC organizations paying more for family med without OB, which is somewhat surprising, where they're paying up to upward of $377,000, with a median in this case being higher than for the non-RHCs compared to the RHCs of $300,000 compared to the $260,000 for the RHCs. This one we did have a few respondents that were providing actually using locums for family medicine without OB, and they were paying the locums physicians $482,000 on average, so a significant high. We do expect locums to always be the most expensive possible way that you're going to pay for a provider, so it's not surprising for that to be a very large outlier. This one, when it came to primary care physicians without OB, this one was more in line with what I expected for independent and contract physicians, tending to be paid more than those that are employed. So you think about it, this may be a situation when I see independent contract physician getting paid $314,000 on average run by an independent hospital compared to $260,000 for employed physician. This may be your independent practice that is in your community where you may own most of the practice, but you contract with a physician to provide the professional services there. And so you pay them some sort of per work RVU rate or some sort of professional services agreement where the provider is working in that clinic, but you're not directly employed. So when I look at this variance between 314 and 260, that is consistent with what we typically see as covering the benefits and the med mal for that provider to be able to pay that. Moving on to the APPs, as we know in rural, we are highly, highly dependent on advanced practice providers. This is the advanced practice providers who also provide OB services. So you can see on here that I have both listing the nurse practitioners and the physician assistants, those that do have RHCs versus those that do not. This is what came out similar to the physicians, where those organizations that do have RHCs, you can see, do pay more than those that do not have RHCs. So for nurse practitioners, the median in compensation was $142,000 compared to $128,000, and then for the PAs, $153,000 compared to just under $120,000. So looking at this, you know, the RHCs, the PAs, and the NPs. The NPs are overall making more than the PAs, but not by a ton. When it comes to those that are not included in the RHCs, for those that are in the RHCs, the PAs are making more than the nurse practitioners, but again, not by a lot. And one of the things that we've been seeing anecdotally in the clinics that we work with is oftentimes more and more organizations are trying to get these numbers closer together. And the reason for that is there's a lot of commentary from the advanced practice providers saying we need to be paid the same amount for the same work. So if, especially in an RHC, if we're both managing our own patient panels, if we're doing the same kind of work, we should get paid the same amount. Where we typically see differences between nurse practitioners and PAs is if one of them, especially when we'll get into some of the PAs and then within the specialties, where the PA might provide surgical assist, where the PA might actually make more money than a nurse practitioner because they're doing a different job. I will say in our own experience, we do see more nurse practitioners with medical directorships and additional compensation aligned with incentive compensation, which may account for sometimes the nurse practitioners making more money than the PAs. So moving on and looking at family medicine without OB services for the APPs. And in this situation, actually, that the organizations, again, consistent with the physician data, that those that did not have RHCs were actually paying more for family med without OB compared to those that include RHCs. So as you can see in here, the nurse practitioners family med without OB are making about $10,000 more in a non-RHC setting rather than in an RHC setting. And then also on the PA side, you're seeing that the family med without OB is making about $25,000 more than those in a non-RHC setting versus in an RHC setting. And so honestly, I don't have a really good explanation for why I'm continuing to see that the non-RHC is paying more on the family med without OB side than what we're seeing on the family med with RHCs. If anybody has any speculations for that, I'd be happy to have that conversation, because this is something that while we've seen it in our some of the clinics we've worked with, there does not seem to be a consistent explanation for why that is the case. I would like to point out that one of the things that may be contributing is, as you will see, the total FTE counts for those that are inclusive of an RHC are much higher than those of the organizations without. And so does that create a tightening of the range, right? Because you have more overall respondents to report what the median compensation is. A stat that I always want to pay attention to is what is the difference in compensation for restricted practices versus unrestricted practice states. So one of the things that we pay attention to is those full practice states. Those ones are the ones where nurse practitioners and physician assistants can practice at the full scope of their license, right? So those ones I go ahead and it's in the appendix, but I went ahead and put it up here on this slide as well so that you can see it visually. Those states that are highlighted in green are a full practice state. The states that are in yellow are reduced practice states, so they can practice a good amount of their license, but oftentimes they will require a collaborative agreement. And then the red practice states that you see are restricted practice states. And in a restricted practice state, not only is a collaborative agreement necessary, but oftentimes there will be additional restrictions on what is the scope of practice that APP can work at. So for example, I live in Tennessee. Tennessee is a very restricted practice state. Oftentimes the nurse practitioners and PAs, they cannot have their own patient panel. They're going to act more likely to be in hopefully a team-based care environment with a physician lead for each one of the patients. And the only patient practice visits that they're doing on their own entirely for patients may be follow-ups or nurse visits, and are rarely doing new patient visits. That is what we tend to see. And so oftentimes, right, the hypothesis is in a restricted practice state where you do not let them practice at their full scope of license, and you are going to need a physician to provide different a collaborative agreement and more supervision, we expect restricted practice states to pay them less, right? You're not allowed to do as many services as in a full practice state, and so you're going to get paid less. So in the data, that's exactly what we typically see, right? You can see in here that the full practice states, which is the lightest color of green, tend to make the most compared to other states. However, the exception with that being is nurse practitioners without OB, wherein there are some reduced practice states that actually pay more than the full practice state. Now, we have not done a detailed analysis of trying to look at this by geography as to whether or not certain states actually end up having higher compensation. So I'll go ahead and call out, because we do a lot of work in the state of Wisconsin, it's a reduced practice state, but we have been seeing increases in compensation in the state of Wisconsin that have been across the board going up faster than some of other states that we do work in. So is that a possible reason for why a reduced practice state may be paying more than a full practice state? Yeah, just some speculation, but it's not significantly more, right? It's 3.5%. But then you look at full practice versus reduced practice for nurse practitioner with OB, you can make substantially more in a full practice state. So, all right, going into specialty care. And specialty care, I will say, is one that last year we did not get a ton of responses on. So I was excited to have a lot more detailed information for our different specialty care services than we've had in the past. Starting out with anesthesiology, recognizing that we do rely very heavily on CRNAs to provide anesthesiology for services. We work with several hospitals that are exclusively CRNA hospitals, where they do not have any MD supervision at all for providing anesthesiology. It's interesting that the range of compensation for CRNAs was a huge range, anywhere from $200,000 at the minimum that we saw to nearly $300,000. It actually came out to just $297,000 for the highest response rate or highest amount of compensation for CRNAs. Median compensation for CRNAs came out to $251,500. This is a little bit higher than what we see reported in the MGMA data, I would like to point out. But Megan and I do actually a lot of work in anesthesiology, and we also look at, there's a website, if any of you have gone to it, called gaswork.com, which Gaswork actually reports all the different job postings for anesthesiology, both MD and CRNAs, and the wide range of responses on that, depending on what the level of call coverage that is required by a CRNA in an organization. So median compensation at $251,000 is not inconsistent with what we're seeing on, websites such as Gaswork. It's a little bit higher than MGMA, but that wide range kind of really depends on the overall level of services that you are expecting from that CRNA. The physician anesthesiology compensation at the low end was $385,000, all the way up to $600,000, with median being $472,000. One thing that we did not ask this year, but we may consider asking for next year, is whether or not any of these providers are getting any of their compensation from providing pain services. One of the trends that we are starting to see in the market is more rural organizations are looking to how they can provide pain services, specifically in a pain clinic, to augment, say you have a relatively new or potentially a slow surgical department, where maybe you have 2 ORs and maybe 1 procedure room that's not being fully utilized at its max capacity. Do you take a CRNA and you put them one day and have a day of pain clinic available for your community? And so understanding whether or not there is that kind of breakout of compensation. Historically, providers who had the specialized training to be able to provide pain services were paid at higher rates than those that provided pure non-pain anesthesiology services. It would also be interesting, another question we may add for next year is whether or not your hospital provides labor and delivery services. We know that the majority of hospitals do, but more and more rural hospitals have closed their OB programs. And how does that impact the overall compensation for anesthesiology, since one of the big drivers that we've seen for anesthesiology compensation is whether or not you need to have 24/7 on-call services by a CRNA or an anesthesiologist to deal with epidurals for labor and delivery. So going on to the other specialties that are provided here. So last year, as we noted, we did not have nearly as many specialties that were responded to, and we did not have the detailed data. So as you can see, we have some big ticket items such as cardiology, GI, orthopedics, and radiology, all making $600,000 plus as median compensation here in rural. And we also have the physician assistants and the nurse practitioner data. So starting out with cardiology, I will say there's a few of these that really stood out to me. Cardiology, for one, being typically this cardiology is non-invasive cardiology. Every now and then you'll get interventional cardiology in rural as well. The median compensation reported from MGMA for rural providers, for cardiology providers, is only $487,000. So when we get the direct data specifically from rural respondents, we're seeing median compensation of $200,000 higher than what we were seeing in the rural respondents from MGMA. Now, nationally, the national median for rural and non-rural within MGMA was $585,000, but this data is showing still $100,000 more than what we were seeing reported in the MGMA data. Another specialty I wanted to point out was actually ENT. ENT surprised me because $240,000 as median compensation was lower than I would have expected, especially since nationally median compensation for an otolaryngologist is $514,000. So to only be making half that in ENT in a rural setting was surprising. I am curious as to, again, this is self-reported data by organizations, and we do ask them to provide it on a 1.0 FTE basis, but whether or not this is using ENT not full-time, and whether or not you're including visiting ENTs that are only coming a few times a week. Neurology was also another one where the data that we were seeing actually pays higher than what is considered the national median. National median for neurology is $364,000, as opposed to this $476,000 that we received the data for. So significant rural premiums compared to the national numbers. And then I also wanted to point out radiology at $750,000. We do actually see that type of compensation a lot in rural for radiology. MGMA reported their rural number as $813,000, but nationally radiology is closer to $580,000. I will say the radiology numbers also were, we were glad to have organizations that actually employ radiologists respond to us, since typically we see radiology as a service that is typically outsourced by a lot of our clients. And the last one I really wanted to point out is with regards to urology. So urology paying $460,000, where the national median for urology is $560,000. So again, this is a service that we typically don't see a lot of in rural organizations. They're more likely to be system hospitals that are providing a urologist that come as a fraction of the time to a rural organization. Very few organizations that we work with, especially critical access hospitals, have actually employed their own urologist. I'd also like to point out on psych, as you will see on here, I have a note that we do not have data for nurse practitioner or physician assistant for psychology or for psychiatry. That number there, the 81,500, those are specifically for LCSWs, licensed clinical social workers, as opposed to NPs and PAs. One thing that we will be hopefully adding for next year is actually asking about telehealth. And for those that are actually receiving some of these services, especially that we see for psychology, pulmonology, we're seeing more of as a telehealth service, telecardiology and teleneuro and also telenephrology are ones that Megan and I are seeing a significant increase on. I also wanted to point out that orthopedics, right? I pointed out on an earlier slide that oftentimes we see physician assistants who are providing surgical assist make more money than the nurse practitioners. So as you can see here in the data, the PAs actually are making less than the nurse practitioners, making $129,000 versus $154,000 for the orthopedic and nurse practitioners. Now, one of the things that we have been seeing is so many organizations have to employ more orthopedic surgeons than they necessarily need to provide 24/7 call coverage, right? So your market demand may say you only need 1.9 or 2.3 orthopedic surgeons, but it's very, very difficult to recruit orthopedic surgeons to provide services on a 1 and 2 call basis. So you end up paying a third orthopedic surgeon to be there. Well, if you have a third orthopedic surgeon, but not necessarily the services the market need for 3 full-time orthopedic surgeons, those organizations are far more likely to use an orthopedic surgeon for first assist rather than an advanced practice provider, as opposed to organizations that we work with that tend to not provide 24/7 call coverage. So they may only have one orthopedist or maybe 2 orthopedists in their organization. They are more likely to use an advanced practice provider partnered with that orthopedic surgeon, either for first assist or be doing follow-up appointments that we're seeing in the days that the surgeon is actually in the OR. So the other specialties that I did not specifically count out, emergency medicine, hospitalist, GI and general surgery, those ones, the numbers actually do line up with what we typically see and what is the nationally reported data. So no significant rural premiums on those services, and they're pretty standard across both national and rural compensation, recognizing some of that those services are actually outsourced. So moving on into other compensation. So additional forms of compensation that people were interested in, and I will go ahead and apologize that I realize that this may be confusing to read, because I realize that the order in which that the types of compensation are paid are actually flipped between physicians and APPs. So you will see sign-on bonus is the first line for physicians, but it's the bottom line for APPs. I'm not sure why we did it that way. So if you're looking at it, don't look straight across. It's top to bottom on the physicians, is bottom to top on the APPs. But if you look at it overall, sign-on bonus, production incentive, medical directorship, and student loan repayment are the most frequently paid types of additional compensation on top of base compensation for physicians. And it's pretty consistent across that also for APPs, except with the exception of medical directorships, with very few APPs getting medical directorships. And the numbers that are reported here are the number of organizations, not the number of FTE physicians that are receiving this. So out of it, 50 out of 199 organizations provided sign-on bonuses for physicians, a very common form. And if you'll recall earlier, I pointed out that 54% of organizations pay 100% base salary, but only 31 organizations indicated that they were paying any sort of production incentive, with 32 providing some sort of incentive. And the reason why is a lot of times people don't look as sign-on bonus, student loan repayments, et cetera. That's not necessarily incentive compensation. Yes, it's incenting you to sign on, or to be come and join an organization, but it's not really considered incentive for your annual day-to-day performance and how you're doing. Bear with me. I'm actually doing this recovering from a bit of a cold, so hence Megan standing in the wings if I really do lose my voice. Getting back to this, on the sign-on bonus that we've been seeing, retention bonuses for those that are staying. More and more organizations, this is an increase from how many we saw previously, provide some sort of retention bonus compared to last year. What I am hoping for is that more organizations are paying retention bonuses because people are staying in those rural communities, and you're paying a retention bonus for somebody to stay, rather than more paying sign-on bonuses, because we're constantly having to recruit and providing large sign-on bonuses in order to get people to join the organization because we've had turnover. Another thing that I would like to point out is you will see that the production incentive for both APPs and physicians, that's a pretty close number, right? As far as the total number of respondents that are providing the production incentive. And so what I'm seeing is more and more organizations start to give APPs the same types of incentives that they've been giving physicians. So especially in the primary care, if you've been providing work RVU or RHC visit or panel size incentives for physicians, they're also doing that for the APPs. So I'm glad to see that number being relatively consistent, although hoping to see that go up over the years. With that, we also wanted to point out the differences between independent hospitals and the health systems, right? The independent hospitals are more likely to provide some sort of incentive compensation for the APPs and the physicians rather than the health systems. Very few health system respondents say that they're providing specific types of incentive compensation. And I have to say that was a bit surprising because we see health systems in the urban areas more likely to provide production incentives and other kinds of incentives to both physicians and APPs rather than the independents. So maybe more and more independent systems are looking at their financial sustainability and recognizing the need to align provider compensation with how the organization is performing. And so they're starting to tie more and more compensation into how are they going to be able to pay for the overall total compensation. Very few organizations do any sort of administrative stipend for APPs, as opposed to the physicians tend to get more of it. And on the medical directorship side, I will say that is pretty consistent with what we see overall for industry, is the number of organizations that provide medical directorships. You know, seeing 57 organizations provide physicians some sort of medical directorship, but very few provide APP medical directorships. You are going to tend to lean towards your physicians to be the head medical director. It really is only in rural organizations that I've ever seen an APP have any sort of medical directorship. So getting into, speaking of medical directorship specifically, getting into a little bit more of the detail with regards to that, what we see as median medical directorship compensation on an annual basis for physicians is $19,000, $13,000 for APPs. We did not have them break out whether or not this was paid as an annual stipend versus are they paying it hourly with a specific amount per hour. That may be a potential more detailed question in the future. We asked for total amounts. I was surprised to see actually just how high the compensation went for organizations as far as the overall medical directorship amount, specifically for the APPs. To see an organization say that they pay an APP an additional $60,000 for medical directorship is really on the high end and higher than what I would have expected. I have seen across different organizations that $76,000 was not surprising. We've seen, depending especially if you have a provider who's developing a completely new program, right? Building orthopedics from scratch at a rural organization, who's also going to be, you know, chief of surgery and really lead and build an OR program. We definitely see types of those services, that directorship compensation be at that really high end amount. The lower end for physicians of that 1,500, oftentimes that's for a director that you're only having them participate in a specific committee, and you're calling it a medical directorship for, you know, some sort of administrative participation. Now, when we look at organizations that do not provide any APPs medical directorship, we do see the median amount being higher. So for independent hospitals, that a median amount of medical directorship was $23,900. And for system-owned hospitals, that median amount is $32,800. This is one where I wanted to show you the breakout specifically for critical access hospitals, since that is where I tend to see more of my APPs providing medical directorship. The range of compensation for MDs was somewhere between $5,000 to $72,000. And then it was a critical access hospital that paid the $60,000 to an APP, but ranging from $8,000 to $60,000. Getting into quality incentives, as I noted previously, there are, Megan, can you advance the slide? Thank you. Overall, there's only 13.1% of respondents actually provide any sort of quality incentive compensation. I will say this number has dropped since pre-pandemic. And I think a really big reason for that is a lot of providers that we work with have pushed back on having part of their compensation tied to quality when they felt like the data associated with their quality incentives was not that accurate, or it was not something that they felt had been consistent enough, or they've gone through some sort of EHR change, and so they don't feel like the data has been pulled at a regular enough basis for them to make decisions off of it. But again, there are still 13% of organizations that are doing that amount. We asked people, they are paying amounts up to, the highest we saw was of $45,000 in a single year for quality of incentive amounts. We asked people what were the different methodologies that they were using for quality incentives. So the majority of organizations that do pay quality incentives are doing some sort of percentage of base compensation increase. So like you get an additional 5% and added to your base salary, you know, or whatever your base salary is, you get an additional 5% for meeting those quality metrics. Some organizations that I will say, this is harder to administer, but can be a great way of tethering quality incentives to productivity, is actually taking whatever their productivity incentive amount is. So they say, let's say they pay $50 per work RVU, and we'll adjust that amount up or down based off of hitting that quality metrics. So in this organization responded specifically that they increased the work RVU conversion amount by up to 15% for meeting quality metrics. We asked people what type of metrics that they were using specifically to base decisions off of paying out incentive compensation. And the most common one was patient satisfaction. Others in that people listed out included hypertension goals, colon screening goals, having specific ACO metrics. And some of them, if you do ACO metrics, oftentimes what we will see is those organizations that have those providers saying your comp can go up and down based off of meeting ACO metrics. That compensation will be tied to whatever the organization actually gets from the ACO. And then participation in closing quality gaps and completing documentation were additional quality incentives that people had. I want to finish out with talking about some other contract provisions that we saw. I noted last year that I was surprised at how many organizations were unaware of which Medicare physician fee schedule they were using for billing or paying out incentive compensation. So obviously, if you are paying out incentive compensation for productivity that you base off of work RVUs are set by CMS on the Medicare physician fee schedule. And organizations we have seen ever since the big change in 2021 from Medicare about this physician fee schedule, some organizations have elected to use older physician fee schedules instead of going immediately to the current physician fee schedule for calculating productivity because of the substantial changes that Medicare had in 2021 to the primary care CPT codes specifically of increasing the work RVU values for that. However, half of organizations still are actually unsure of what they use. That is scary because from a legal standpoint, they have to be using the current one for billing, and then for tracking for productivity for providers, especially if you're doing any sort of benchmarking, you want to be consistent with that. You're using the appropriate year with whatever you're tracking to. Another thing that we asked organizations is trying to compare to what are the overall level of services that the providers are giving, and whether or not they have a requirement for having a specific number of patient-facing hours. 38 organizations indicated that they do not have any sort of requirement at all in their contracts or for their providers. So their providers could be working 10 hours, they could be working 40 hours, they could be working 60 hours, but they don't have a specific requirement. Other organizations noted that they do have a requirement. We did see most frequently, if you're going to put it in a contract, that they have at least 30 hours being required for patient-facing hours. I would say this is really important for RHCs. So we did see more RHCs noted that they have a contract requirement rather than non-RHCs. And the reason for that is the calculation of minimum productivity thresholds and the standards that are tied to the FTE, and being able to calculate specifically that clinical FTE of your providers that you have in the rural health clinic for calculating out the number of visits that you needed to hit your minimum productivity threshold. Now, with the new RHC rules that did get finalized in November, saying that minimum productivity threshold is going away for 2025 in that final rule, I hope I don't see this go away as a requirement. I hope I actually see those numbers continue to increase about organizations holding providers to a specific standard, but I'm curious as to whether or not it'll impact the variance that we see between RHCs that require it versus non-RHCs. So to close out, because I know we are coming at time here, and I know that there was supposed to be some questions, is the 2027 survey. We will start issuing that in mid-January. We usually leave it open until the end of February, so be on the lookout. One of the things you will see, this is high level of what is included in the report. So everybody can go on and download the survey today. For those of you who actually participated in the survey, you get a more comprehensive report that actually reports out the 10th, 25th, 75th, and 90th percentiles. So everything I showed here today that showed median compensation, you actually get the 10th all the way through the 90th. We do that as a huge thank you to those that actually take the time to fill out this survey. The feedback I get from most people is that it does take less than 30 minutes to fill out the survey when they get their data together. So please consider filling out the survey next year. You get, the benefit of getting access to a lot more data than the general public gets access to. And also, the more people who respond to the survey, the better data that we have. We'll continue to update it and distribute it annually. If you have feedback about additional questions, organizations have said that they are willing to provide more data. So we are planning on actually adding in productivity information into the 2026 survey. So in 2025, we will still stick with compensation only questions, but in 2026, we will be adding productivity information around visits and work RVUs and potentially some more financial information. So again, if you would like to receive the survey directly, please let us know. Or if you want to make sure you're on the list of people who receive the survey next year, let us know, and we will make sure when that survey is distributed and goes live in mid-January that you are included on that list. So with that being said, I will go ahead and open it up to if there are any questions or anything from you, Cody.
Thank you, Opal. I'm sorry, my thing won't come off. It doesn't want to come off mute very well. So I apologize for the issues with the slides earlier, but we have some questions we could get to. Opal, first, what was the total number of responses that had FP physicians who do OB? Do you know?
Bear with me. That, sorry, you said primary care physicians that provide OB?
Yes.
Give me a second. I do have the number. I just have to pull it up on my screen. I minimized everything so I wouldn't be distracted during the presentation.
Well, and maybe so the slides wouldn't have issues, right?
Well, that too. So total number of with OB. Let me scroll. Family medicine with OB. Number of organizations is 23, 14. We had 50 organizations family med with OB.
Wonderful, thank you. Blake, if that answers your question, great. If not, just let me know. Another question, why do RHCs pay higher?
That's a great question. So again, I will say this is just based off of our experience of working with those. I think RHCs pay overall higher for a couple of reasons. One, prior to the change in the RHC rules with the cap, you could pass, right, if you were in a provider organization with less than 50 beds, you could get access to uncapped cost-based reimbursement for the calculation and your all-inclusive rate. And so those organizations, especially that are grandfathered in, that were able to get higher levels of reimbursement because it was cost-based, so they could actually pay their providers more and actually get it reimbursed and still be able to make money in those RHCs. So a lot of organizations use that as a recruitment tool to be able to get, especially physicians, more physicians into their RHCs. And as long as they've maintained that cap or maintained those services and that status, they've been able to grandfather that going forward until eventually, you know, the legislative cap approaches whatever their rate is. So I'm seeing a lot of those organizations that are getting an all-inclusive rate of, you know, over 240 bucks an hour, or sorry, 240 bucks a visit. They can afford to pay the physicians more and be able to get them and give them incentive compensation, you know, that non-RHCs that are especially tied to some sort of freestanding rate. You know, if you're only getting $85 a visit in your non-RHC versus somebody who's going to get over 200, then there's a significant benefit for those RHCs to be able, gives them a huge advantage in the recruitment.
Okay, thank you, Opal. Quick question on telehospitalists. Do you have any information relative to the compensation for telehospital services?
Not in this survey. However, we have worked with organizations that telehospitals. So if you want to have a call, I'm happy to have that conversation about what we're seeing from some of our clients on telehospitalists. It has not been very common. From what we've seen, we're seeing more and more organizations that are going to a pure nurse practitioner hospitalist model and only use telehospitalists as a backup type service. But yeah, we did not ask telehealth questions on this past survey, so I don't have it specifically in the new survey data.
Okay, great, thank you. And I know you guys will share some information. If you want to reach out to the team afterwards, don't hesitate to get in touch with me, and I will make sure that you can do so. Another question that came in, Opal, was there any noticeable increase in a particular specialty in rural areas that wasn't there before?
Oh, that was not there before. I was going to say, I saw overall comp went up across the board. I did not see any specialty compared to last year really go down, with the exception of hospitalists, not in necessarily this survey, but one thing that we've seen is hospitalists kind of stayed flat. The biggest jump I saw from previously from last year probably would have been in cardiology. Cardiology went up a good amount. I want to say the previous number was in the lower 600, so to go, you know, up to 684 is a sizable jump. And then the other one, like I said, the ENT number was surprising to me because I feel the ENT number was previously higher as well. And for that to drop down to 240 was really surprising. So, and then I will say, I'll put it this way, CRNA compensation is one of the ones that I'm watching very, very closely, because while median 251 is right on target from what I would expect for median compensation, the ranges that we're seeing organizations not necessarily pay this, but get asked to pay this. We are having more and more CRNAs asking for compensation close to 300 or north of 300. Again, not necessarily organizations paying that and saying yes, but the ask is there.
Okay, thank you. If you have any more questions, go ahead and put those in. We've got a couple more minutes. I do see Blake had a clarification question. I think he's looking for when he asked for the, what am I trying to say? A noticeable increase. I think he meant in the responses versus the compensation.
Oh, sorry. Yeah, we had, what was it? We had 199 respondents this year compared to 156. So I think, honestly, I have to give a huge shout out to both NRHA, but also NOSOR. Last year, NOSOR, we just reached out to our direct contacts at NOSOR for help with that. And the fact that NOSOR joined us as a sponsor this year, they were able to reach out to more and more organizations to be able to participate specifically in responding. So, and we did have the same number of states respond this year as last year, but definitely I could tell that the states that have have a very active State Office of Rural Health had more responses. So we do appreciate that.
Okay, wonderful. Well, thank you so much for all the information. I'm going to turn it over to you for closing remarks before I end us out for the day.
Sorry, Cody, I was coughing over you. What was that?
I'm just going to turn it over to you for some closing remarks before I let us go for the day.
Okay, great, thank you. And again, I apologize, you guys. I do appreciate your guys' grace as far as dealing with my nasally cold that I am speaking through to present this to you. I can't thank you guys enough for everybody who responded to the survey. It is really important information that we get out there. It's very important to have rural specific information, whether it's for compensation or for staffing ratios or for, target margins and by department and what ED throughput should look like. Having that kind of data that is specific to our rural organizations, we are different. We are not like the big metro hospitals in Chicago or even frankly, in Kansas City, where Cody, near Cody or me in Nashville, like our rural hospitals, we know that we operate differently and our needs are different and we have different struggles, and that the services that we expect of our providers are going to be different, whether it's a general surgeon or an ED doc or even, a hospitalist. What we ask of them is different. And so having compensation information that is specific to what the services that we experience in our providers, so we can say we're making apples to apples comparisons and know we're being competitive, is absolutely critical to our overall financial health and sustainability for rural organizations. So I think that this is really critical information for people to have. So thank you to those that provide it, and we really hope that more will do so in the future. I would love to see, us have 500 respondents at some point, with, really feeling like we're filling up this map of who is provided. I would love to be able to have a survey where you can click down and just pull up your state because there's enough respondents from your state for you to feel like you have really good information. So, and thank you again, Cody, for moderating today and helping us out.
Absolutely. Thank you so much, Opal, and get to feeling better. Thank you everyone for joining us today. We do hope this session gave you some new insights to take back to your organization, have some great conversations about. As a reminder, this session was recorded and you will receive an email later today so that you can revisit anything that you found helpful. Before you go, please don't forget, we would love to hear from you. If you could complete that brief survey at the end, it does help us keep these sessions relevant and impactful. Also, if you're looking for additional ways to grow your leadership skills or expand your team's impact, please visit nrhasc.com for more educational resources. And if you'd like to learn more about our leadership development programs or discuss how they could benefit you, please feel free to reach out to me at any time. I'm always happy to help. With that, everyone have a great day, stay warm, and we look forward to seeing you at our next event. Thank you, Opal. Thank you, Stroudwater team.